Welcome to the deep dive. Today, we're grabbing a stack of notes, maybe your revision notes, actually, and we're focusing in on a condition you absolutely need to know, epiglottitis.
Exactly. Think of this as us helping you turn those study points into, well, really high-yield, memorable nuggets of knowledge.
Specifically for you, to help lock this down, we want this stuff to stick.
And we're sticking strictly to the material provided in these sources, keeping it really focused.
Yeah, no outside info, just what's here. Okay, let's
Okay.
let's unpack this, starting right at the beginning. What is epiglottitis?
Okay, so at its core, epiglottitis is a severe inflammation and swelling of the epiglottis, and it needs immediate attention. It can be life-threatening.
Right, the epiglottis, that little flap of cartilage. Why is it swelling such a massive deal?
Well, its job is crucial, isn't it? It's like a lid covering your windpipe, your trachea, when you swallow. Stops food going down the wrong way.
Into the lungs, yeah.
Exactly. So when it gets inflamed and swells right up, it can physically block that opening. Just imagine trying to breathe past that swelling.
Okay, yeah, I see the problem.
Yeah.
So, a key takeaway right from the start then, from this material. Severe sore throat, trouble swallowing, maybe not keeping fluids down.
High suspicion. Urgent assessment needed.
Yeah.
It's definitely not just a standard sore throat.
Got it.
And the notes you've got there clarify things a bit further. Acute epiglottitis is the epiglottis itself, but you might also see supraglottitis.
Oh, what's that?
That's when the inflammation spreads to the tissues around the epiglottis, sort of above the vocal cords.
Ah, okay.
And the critical sign, the thing that really shouts danger, because this rapid swelling narrowing the airway, is stridor.
That noisy breathing sound.
Yes, that high-pitched noise when they breathe in, usually. The sources are really clear.
There.
Stridor in this context is a major, major warning sign.
Stridor equals red flag. Okay, so what actually causes this inflammation? The material suggests it's not just one thing anymore.
That's right. Historically, the big one, the classic cause, was Haemophilus influenza type B Haba.
Right, the one we vaccinate against.
Precisely. That used to be the main culprit, especially in kids, before the vaccine became widespread. But these notes make it clear the picture is much broader now.
Like what else?
Well, you see other bacteria, things like Streptococcus, Staphylococcus aureus. And interestingly, the common bugs can differ a bit between children and adults.
Oh, how so?
The notes mention Streptococcus pneumoniae and actually even Hib sometimes in adults, whereas in children, it might still be Hib or other Haemophilus species.
Hub can still get adults. That's definitely worth noting.
It can, yeah, though it's less common if you're vaccinated, obviously.
Yeah.
The sources also highlight causes specifically in people who are immunocompromised.
Okay, like who?
They list Pseudomonas, aeruginosa, and Candida species. And then there are viral causes too, like herpes simplex virus, often complicated by a bacterial infection on top.
So it can get complicated.
It can. And maybe surprisingly, there are even non-infectious causes listed.
Really? Non-infectious? Like what?
Things like direct trauma to the throat area, maybe a foreign body getting lodged there, or even certain systemic diseases. Polyangiitis, sarcoidosis are mentioned,
Wow.
and reactive epiglottitis following head and neck chemotherapy is another one noted in the material. So yeah, quite a wide range of triggers beyond just that classic Hib infection.
That variety seems really key for revision, doesn't it? It's not just Hib. So given all that, who's actually more likely to get it? What are the risk factors the notes point out?
Well, the historical risk factor that really jumps out is age, specifically kids between 2 and 6 years old.
Mm-hmm.
But like we said, that's very much tied to the pre-Hib vaccine era.
Right, because Hib was the main driver then.
Exactly. Other risk factors listed here are having a compromised immune system, which makes sense with all the infectious causes and living in crowded conditions.
Okay. Increases exposure, I suppose.
That's the idea.
So just stepping back for a second, pathophysiology. How does the cause, whatever it is, infection, trauma, actually lead to the clinical picture? What's the basic mechanism outlined?
It's actually pretty straightforward, according to this material. The initial trigger, whatever it might be, sets off an inflammatory response in the epiglottis and the tissues around it.
Okay. Standard inflammation.
Right. But the critical thing here is the swelling that results from that inflammation, the edema. It physically enlarges the epiglottis.
And that blocks the airway.
Precisely. It encroaches on the airway opening, narrows it, and can eventually obstruct it completely. That's what leads to the difficulty breathing, the respiratory distress. It's fundamentally a mechanical blockage from swelling.
Got it. Simple but deadly. Now, while the symptoms sound pretty dramatic, Could it be mistaken for other things? What does the material list as important differential diagnoses?
Yeah, this is really crucial, especially in an emergency setting. The sources list quite a few conditions that might look similar initially.
Like what?
Things like croup, tonsillitis, an abscess, either peritonsillar or retropharyngeal, also pharyngitis, laryngitis, and just general upper respiratory infections.
Croup is another one that causes stridor, right? Especially in kids. How do you tell them apart quickly given the urgency with epiglottitis?
Well, the specific clinical features we'll get to are key differentiators. But the main point the material stresses is that epiglottitis is so dangerous, you have to consider it and evaluate for it promptly, even if it turns out to be something less severe like croup. You can't afford to miss it.
Rule out the worst first. Makes sense. Okay, let's zoom out then. Epidemiology. Who's getting this now? Where? What does the UK picture look like according to these notes?
This is where it gets really interesting and definitely a high-yield point for revision. The impact of the BO vaccine has been, well, dramatic.
Huge success story, right?
Absolutely. The material states the incidence dropped significantly once routine childhood vaccination started. It's now considered extremely rare in vaccinated children.
That's great news.
It is. The overall prevalence is low, maybe 1 to 4 people per 100,000, something like that. But the really striking thing highlighted here is the shift. There's an increased prevalence now seen in adults.
Really? So it's flipped from being mainly a childhood illness.
That's the trend this information points towards, yeah. And in adults, it's often down to those other bacteria we mentioned, not just Hib. It seems to affect people more in their 40s and 50s, and maybe slightly more common in men.
And often underlying conditions.
Yes. The notes mention that many adults who get it have other health issues that might affect their immunity, which contrasts sharply with that historical picture of kids aged 2 to 5 being the main group affected.
That whole epidemiological shift because of the vaccine, that's definitely something to remember.
It really shows the real-world impact of vaccination programs.
Okay, let's get into the clinical features. This is crucial for diagnosis, right? What does it actually look like? What are the common signs and symptoms in the notes?
Right, this is key. The notes list several classic features. Often it's a sudden onset, high fever, a really severe sore throat, often described as worse than you'd expect from looking in the throat.
Out of proportion, yeah.
Exactly. Difficulty swallowing, dysphagia, often so bad they start drooling because they just can't swallow their saliva. Their voice might sound muffled, sometimes called a hot potato voice that's dysphonia, and often rapid breathing.
Is there anything specific about how they hold themselves? Any postures or behaviors that are big clues, especially with children?
Yes, there's a very distinctive posture. This is a key memory tip for epiglottitis. The tripod position.
Tripod, how does that look?
The material describes it as leaning forward, often with their hands on their knees or a surface, mouth open, neck slightly extended. They're basically trying to maximize the airway opening.
Trying to get more air in.
Precisely. In kids, you might also see restlessness, irritability, and they'll often refuse point blank to lie down because that makes the obstruction worse.
That combination, the drooling, the difficulty swallowing, the distress, and that tripod posture is highly suggestive, especially in a child.
Tripod position and drooling. Okay, anchoring those. Do these notes say if the presentation differs much between kids and adults? They do contrast them, yes. Young children often have that really rapid, dramatic onset. Severe swallowing problems, lots of drooling, obvious respiratory distress, often tripoding.
And adults?
Adults still typically get a very severe sore throat, but the notes suggest they might have a slightly lower risk of that super fast deterioration. However, any adult with an unexplained severe sore throat still needs urgent referral to ENT for a proper look at the larynx.
Still serious, just maybe not quite as explosive sometimes. Any other symptoms listed?
Yeah, a few others. High temperature, tachycardia, so a fast heart rate, tenderness when you press gently on the front of the neck over the hyoid bone area, sometimes ear pain or swollen glands in the neck, cervical lymphadenopathy.
And the really severe signs.
In severe cases, the notes emphasize obvious difficulty breathing, dysmonia, severe dysphagia and dysphonia, clear respiratory distress, and that stridor we mentioned earlier. And again, the sources explicitly call stridor in this situation a surgical emergency.
They really hammer that point home. Stridor means act now, and the rapid progression is key too.
Absolutely. The symptoms can worsen incredibly quickly. Time is absolutely critical.
So you've got this high suspicion based on how the patient looks and sounds. How do you actually confirm it? What investigations are mentioned in this material?
Okay, this is a really crucial point about priorities. The sources are very clear. Diagnosis is mostly based on the clinical picture and examination. But, and this is the most important part, Airway management always comes first.
Airway, breathing, circulation, always.
Always. Investigations only happen after the airway is secured and stable, especially if there's any doubt about its safety.
Airway first, tests second. Understood. So once it is safe, what are the diagnostic methods?
The gold standard, according to these notes, is direct visualization of the epiglottis, looking right at it.
How's that done?
Usually with a flexible fiber optic scope, ideally by someone experienced like an anesthetist or ENT surgeon. And sometimes, particularly in kids where you risk provoking airway spasm, it needs to be done under general anesthesia in a controlled setting like the operating room. Fiber optic laryngoscopy is named as the gold standard.
So you see the swollen red epiglottis.
Exactly. Often described as cherry red, swollen, maybe with secretions pooling around it. The sources also mentioned using a lateral neck X-ray.
When would you use that?
Cautiously. Maybe if direct visualization is difficult or considered too risky initially.
And there's that classic X-ray finding, isn't there? Another memory tip.
Yes, another absolutely vital one for your revision. The thumbprint sign.
Thumbprint sign.
On that lateral neck X-ray view, the swollen, enlarged epiglottis can look just like the silhouette of an adult's thumb sticking into the airway space. It's quite distinctive.
Thumbprint sign. Got it. Any other X-ray features mentioned?
Yes, the notes list a few others. Loss of the normal airspace behind the tongue root, the vallecula, thickening of the aryepiglottic folds nearby, a distended hypopharynx, and maybe some straightening of the normal neck curve.
Okay, so X-ray can be helpful. What about blood tests or swabs?
Again, typically done after the airway is secure. The sources mention things like a full blood count, blood cultures if the patient seems systemically unwell, maybe an epiglottal culture.
But carefully.
Very carefully, usually only if the patient is already intubated, because poking around back there could trigger airway closure. Throat swabs can also be taken once it's safe. And if there's a worry about an abscess forming, a CT or MRI might be needed.
Right. Always keeping that airway safety front and center. Which leads us perfectly into management. What is the absolute #1 priority, and how do you manage this according to the notes?
Number one, top priority, cannot stress this enough, secure the airway. The material is emphatic.
Yeah. What are the options?
In severe cases, it means immediate endotracheal intubation, putting a breathing tube into the windpipe.
Okay.
If that's not possible, maybe because the swelling is too bad, a surgical airway might be needed like a tracheostomy.
Okay.
Bag valve mask ventilation can provide temporary support. But crucially, the sources point out that supraglottic airways, things like LMAs, are not effective here.
Why?
Because the obstruction is above where those devices sit. They won't bypass the swollen epiglottis. If the patient is still breathing okay on their own, you give supplemental oxygen, but stay ready for things to deteriorate rapidly.
Be prepared to intubate or get surgical help. What about treating the underlying cause, assuming it's bacterial?
Antibiotics are key, yes. The sources recommend starting intravenous or IV antibiotics, ideally after taking blood cultures, if you could do that without delaying airway management.
What kind of antibiotics?
The typical choice mentioned is a third-generation cephalosporin, something like ceftriaxone, given IV for around 7 to 10 days. They also mention considering adding cover for MRSA if that's suspected.
Okay. And anything else, non-drug measures?
Yes, comfort is really important, particularly for children. You want to avoid causing anxiety, as distress can make breathing worse. Let them stay in a position they find comfortable, often sitting up, maybe on a parent's lap. Avoid painful procedures unless absolutely necessary and you're fully prepared to manage the airway. Exactly. So the notes basically summarize management as emergency referral if there's stridor or obstruction signs.
Right.
Watch closely for deterioration, especially in kids. 5E antibiotics. Intubation if needed. Surgical airway if intubation fails. And draining any abscess that might form.
And prevention. That links back to the vaccine, right?
Absolutely. The material highlights the Hib vaccine in the routine childhood schedule as the primary prevention strategy.
Makes sense. Okay, what about the outlook? How do patients typically do? What does the prognosis section say?
The notes are quite positive here, actually. They emphasize that with prompt diagnosis and the right management, the prognosis is significantly improved.
So catching it early and treating it properly really works.
It makes a massive difference. If it's left untreated or treatment is delayed, it can quickly lead to severe respiratory problems and even death. But the good news is, the majority of patients who are managed appropriately recover well, without lasting complications.
Any specific figures mentioned?
Yeah, the sources note that getting the diagnosis early can actually reduce how many people need intubation, citing figures like maybe only 15% in some studies. And generally, outcomes seem a bit better in adults than in children, with fewer adults needing intubation.
And the vaccine impact again?
Yes, they reiterate that the incidence is way down where routine high vaccination is in place.
Okay, that's good to hear. Finally then, complications. What can go wrong even with treatment or if it's missed initially?
The material lists several serious potential complications. Things like respiratory failure, developing pneumonia, or sepsis, a bloodstream infection.
Those can happen even if treated.
Yes, if the case is particularly severe or things don't go smoothly, and if it's truly untreated or significantly delayed,
What then?
the risks go up. The list includes abscess formation, like a collection of pus, and the notes mention one series where this happened in 25% of cases, which is quite high. Also meningitis, pneumothorax, collapsed lung, sepsis again, and rarely pneumomediastinitis, which is air tracking into the chest cavity.
Wow, those are really serious consequences. It just underlines again why being suspicious and acting fast is so critical for this condition.
Absolutely. Vigilance and timely action are the keys to preventing those really bad outcomes.
Well, that was quite the deep dive. We worked through this material on epiglottitis, covered what it is, the surprisingly wide range of causes now, the risk factors, how that swelling actually blocks the airway.
What other conditions you need to think about, that really interesting shift in epidemiology towards adults.
The crucial signs like tripoding and drooling, the thumbprint sign memory tip for the X-ray, how you investigate cautiously.
The absolute priority of airway management, then antibiotics, the generally good prognosis if caught early.
And those potentially nasty complications if it's missed. Phew.
And remember, we've pulled all of this directly from the revision notes you provided, focusing on making those key facts really stick for your studies.
Yeah, hopefully this has helped solidify this really important topic for you.
You know, if we just take a step back and think about the bigger picture from this material, despite the amazing success of the HIT vaccine, the fact that we're seeing more adult cases, often from different bacteria or even non-infectious causes,
Yeah.
it just means that clinical vigilance is still absolutely crucial, doesn't it? You can't relax just because childhood HIP cases are rare now. Keeping that high index of suspicion, especially in an adult with a severe sore throat that seems out of proportion, that remains vital.
That's a really important final thought. The picture has changed, but the danger hasn't disappeared.
Great point. Well, thank you for joining us for this deep dive.
Our pleasure.
And if you are looking for more resources specifically designed for this kind of high-yield medical revision, do check out pastthemsra.com.
And also freemessery.com. They're built to help you focus on exactly this kind of essential information.
Definitely worth a look. Thanks again for tuning in, and we look forward to the next deep dive.